Hi, I'm Jamie Thakrar. I'm a Postdoctoral Research Fellow at the University of Sussex, and today I'm going to be presenting my pre-registration poster, Brain Connectivity and Patient-Reported Outcomes in People Living with HIV with Symptoms of Insomnia Switching Integrase Inhibitor-Based Antiretroviral Therapy, and this is an RCT, which we call the BIC CNS Study. HIV continues to be a global public health issue, having claimed almost 33 million lives so far. HIV infection has become a manageable chronic health condition, though, enabling people living with HIV to lead long and healthy lives. In 2019, there were approximately 38 million people living with HIV worldwide and 105,000 people living with HIV in the UK. 98% of people diagnosed with HIV in the UK are on antiretroviral therapy, and 97% of those on treatment are virally suppressed, meaning they cannot pass the virus on. Combination antiretroviral therapy, which we call CART, is where multiple drugs are combined for use, and is now the most widely used treatment regimen for people living with HIV in the UK. HIV is the name given to a group of retroviruses that primarily target CD4 T cells and causes progressive loss of these cells over time. In untreated people living with HIV, severe immunodeficiency can emerge, resulting in the manifestation of AIDS. Although HIV is recognized for its direct effect on the cellular immune system through depletion of infected CD4 lymphocytes, it also has broad effects on the CNS. The term HIV-associated neurocognitive disorder, or HAND, is used to describe the spectrum of neurocognitive dysfunction linked to HIV infection. Here on the right, you can see a graphic illustrating how HIV has the innate ability to bind to receptors that are expressed on circulating leukocytes in the blood. Once bound, recruitment of these leukocytes into the brain across the blood-brain barrier is possible via several hypothesized mechanisms. The ease at which these infected host cells migrate across the blood-brain barrier surpasses the ability for therapeutic drugs to complete the same task. HIV can enter the CNS during the very early stages of infection, and persistent CNS HIV infection and inflammation probably contribute to the development of HAND. The brain can then subsequently serve as a reservoir for ongoing HIV replication, even when systemic viral suppression has already been achieved. HAND can remain in patients treated with CART, and its effect on survival, quality of life, and everyday functioning are very severe. The impact of CART on the CNS. The benefits of CART for HIV replication and transmission control have led to its universal recommendation. Neuropsychiatric symptoms, though, are very common in people living with HIV who are receiving CART therapy. Emerging data from cohort studies suggest higher risk of CNS adverse events for the integrase inhibitor, which is one of the antiretroviral drugs called dolutegravir, and these regimens that contain dolutegravir compared to others. And insomnia is the most common symptom reported. And here you can just see a list of the many toxicities, and shows CNS effects and insomnia as one of the highest reported. And also here we're looking at the two drugs we're trialing in our study, which I'll describe a little bit more later. But we're looking at dolutegravir, which is what our patients are currently on, and bictegravir, which is the main component of the drug that we're switching them to. And these are some of their already ongoing side effects that have been reported. Antiretroviral toxicity is a common cause for therapy modification, with around a quarter of individuals on first-line CART therapy changing treatment due to the onset of toxicity, including CNS toxicity, which manifests clinically with other neuropsychiatric symptoms. A review of 28 cohort studies showed 1 to 8% of patients across the range of studies discontinued dolutegravir-containing treatments due to CNS-related adverse events. A randomized trial evaluating the neurotoxicity of a dolutegravir-containing CART Triumeq to an alternative showed reversibility of the neurotoxicity after the switch. They showed significant improvement in neuropsychiatric symptoms at weeks 4, 12, and 24, and also an improvement in cognitive function. Different antiretroviral agents and combinations may have differing effects on cerebral function, and these are well recognized between the non-nucleoside reverse transcriptase inhibitors and protease inhibitors, the more traditional antiretroviral therapies. But less data exists for this type of difference between the integrase inhibitors like dolutegravir, and even less so looking at people switching from dolutegravir to bictegravir using fMRI as the cerebral function measure. fMRI has shown promise as a method to determine differences in cerebral function parameters between antiretroviral agents and their combinations. Recent data from our group demonstrated changes in brain connectivity in virologically suppressed people living with HIV with no neuropsychiatric symptoms. Here they switched from raltegravir to dolutegravir-containing CART. Using fMRI, we were able to look at the resting connectivity of the dorsal attention network, associative visual network, and sensory motor network. And in the figure here, you can see the masks and the areas of enhanced activation before and after the switch. In addition, a behavioral stop signal reaction times task was used to evaluate inhibitory control with no significant changes in brain activation seen at day 120 from baseline. Also, poor inhibitory control has been associated with sleep difficulties and cognitive impairment, even in HIV-negative individuals. Recruitment for this study will be done via the Lawson Unit Clinic. We've identified 150 patients within the University Hospital Sussex who are currently receiving Triumeq, and the clinic will be sending out the Insomnia Severity Index to identify which of these patients have experienced sleep difficulties, and all those who qualify will be invited to consider participation. The study is actually going to be done across 2 sites, and 23 of our participants will actually be recruited via the clinic at Imperial College London Hospitals. And here you can just see a list of the inclusion and exclusion criteria for this study. In the BIC CNS study, participants will be switching away from dolutegravir to bictegravir, which I mentioned earlier, and we'll be looking at changes in BOLD at baseline and 120 days post-switch. This will be done in people living with HIV who have symptoms of insomnia and score 8 or above in the insomnia index. We'll be looking at recruiting 23 participants in each group, so 23 will switch and 23 will remain on their previous dolutegravir-based treatment, and the interaction of interest in our study will be switch status by time point. We hypothesize that switching will be associated with changes in brain activity measured via whole brain fMRI and in frontostriatal connectivity in resting and task fMRI with the stop signal reaction time task, and you can see an example of this task in the figure here. Hopefully we'll have some exciting data to report at the next meeting, and here are a list of references used in this presentation. And thank you to my supervisor, Dr. Jaime Vera, to Charlotte Ray, who's one of our key collaborators on the neuroimaging part of this study, and all the lovely people listed here, and Gilead Life Sciences have been funding this work. Thank you.